I confirm we are now live, Krishni.
Thank you, Tom, and good morning, everybody. Welcome to our first public meeting of 2023 for the Integrated Care Board for NHS Herefordshire and Worcestershire. May I take the opportunity to wish everyone Happy New Year. It does feel a bit late in the day, but it's the first board of the year, so I think it is an opportunity just to recognise that we're into a new year. We haven't had any apologies, so delighted that everyone is able to be here. I just want to check whether there are any declarations of interest for items on the agenda, please. Obviously, we have our register of interests available, but if there's anything specific that anyone wants to declare an interest about on the agenda, then we have an opportunity now. If people don't signal that, then I'll move on to the next item. So item number 4 is our governance log, including the board forward plan. 'Tis therefore noting there are no outstanding actions on the governance log, and obviously it details a number of things around decisions we've made, etc. So it's just there for noting. If anyone's got any comments, then again, please feel free to highlight. And just to remind you, preferably use the raise hands facility available on Microsoft Teams. Otherwise, if that's not working for you, then please do raise your hand if you want to physically raise your hand if you want to signal to me. And also just to remind you that our preference is not to use the chat for anything that we would like to record for the public meeting. So item number 5, it's the minutes of the previous meeting. Can I just check any points of accuracy first and foremost, please? Is everyone confident and comfortable that the minutes are an accurate reflection of our previous meeting? Yes, I can see nods. Excellent. Thank you very much. So I'll take that as approved. Are there any matters arising from that we hadn't covered in our action sheet that anyone wants to highlight? No? Okay, good. So we move on to our first main item, which is patient and public voice. We do have a question from a member of the public. The question has been received from David Trigger, who's a patient representative. And the question is, what steps are the ICB taking to ensure that the concept of end PJ paralysis, pyjama paralysis, I think that refers to, is being followed in local healthcare facilities to ensure that patients are not subjected to deconditioning and thereby lose the ability to walk? Certainly a recruiting boost for OTs and physios would be well worthwhile. So that's a question from David Trigger, and I believe Kath Cobain, our chief nurse, is going to respond. Kath, please.
Thank you, Chair, and thank you for the question. Firstly, delighted to hear that your partner is recovering so well and that their mobility is improving. Mobility is important throughout life. Little and often, all makes a difference. That is why we as a system have signed up to the Reconditioning Games, which focuses on inpatient mobility. We are committed to ensuring and embracing this initiative in full, and whilst pressures have impacted delivery at the pace that we would have liked to, it is definitely moving forward. Thank you. Sorry for the bit of interruption in that.
Thank you, Kath. I think there might have been a little technical glitch there, but I think we got the sense of that. So I think Kath was talking about the reconditioning initiative that is very high on our agenda. Thank you, and thank you for the question, David. So we move on actually back to you, Kath, now for our patient story. which I believe has a mental health aspect to it, which actually is helpful in the context of a deep dive on mental health on our agenda. So over to you again, Kath.
Absolutely, and thank you, Chair. Oh, I'm pleased to note that the echo is gone, so the glitch has gone as well. So as this would have been much more difficult over a longer period of time. Okay, so thank you. And yes, this is a patient story of a mental health experience. So the patient experience today highlights the factors that influenced a young man's journey from anxiety to suicidal thoughts and then on to recovery. The individual and his wife have given consent to this detail being shared, but wish to remain anonymous. They will be referred to as Andrew and Annabelle. Following the death by suicide of a close relative in 2018, Andrew experienced increasing feelings of anxiety and a slow decline in his mental health. The COVID-19 pandemic resulted in increased pressure. Annabelle was shielding and Andrew was worried about catching the virus at work and bringing it into his home. His symptoms of anxiety and panic continued to increase. By August 2020, Andrew made what felt like a bold step to talk to his GP. He declined medication and the outcome was to refer to Healthy Minds, which he did the same day. Andrew had an initial call with a Healthy Minds practitioner. He was advised that the wait for therapy was long. In October 2020, Andrew returned to his GP as symptoms continued to worsen whilst he awaited therapy. Andrew had an initial call. And it continued to worsen whilst he awaited therapy. Andrew agreed to try some medication for anxiety. Andrew's GP continued to keep in touch with him, checking on his welfare and adjusting his medication dose. In December, the Healthy Minds team contacted Andrew to see if he still wanted to await therapy. Due to his worsening presentation, he was spoken to by a clinician, advised of a diagnosis of obsessive compulsive disorder and that he would need to be seen by a more specialist team. A referral was made onto a new waiting list. By April 2021, Andrew's anxiety was much worse. His sleep was affected and he began to have intrusive thoughts of suicide. By September, he was unable to function at work. He felt overwhelmed and was diagnosed with depression. His GP now prescribed an antidepressant. Andrew was provided with contact numbers for the Samaritans and for the urgent mental health line. In October 2021, Andrew started to see a therapist. The medication had eased some of the intrusive thoughts and he was hopeful that therapy would make a difference. His wife, Annabelle, continued to work hard to help to keep Andrew safe. She was a strong protective factor. Some days she would need to lock the doors to stop Andrew from leaving the house. The thoughts included driving his car into a bridge. On New Year's Eve, Andrew had strong thoughts of ending his life. In desperation, Annabelle called the GP. The GP offered a face-to-face appointment, but Andrew refused to attend. The GP advised Annabelle to call the urgent mental health line and, if necessary, call 999. Annabelle called the urgent mental health line, explained the situation and advised that she felt she could no longer help keep Andrew safe. Annabelle explained that Andrew was aware that she was making the call, but was too unwell to speak on the phone. Annabelle was informed that without Andrew's engagement, they couldn't help. Annabelle does not recall any advice being given. They remained locked in the house until Andrew calmed down. In January, Andrew saw his GP and his medication was changed. He was continuing with weekly therapy, but had lost his job. He was then referred to a team to support him to return to employment. By mid-February, the change in medication had started to further reduce suicidal thoughts, and therapy was really starting to help equip him with the coping strategies. He had a number of appointments with the team, helping him to find employment, which was really, really helpful. Later in 2022, he found another job, was eventually discharged from therapy. He has made a good recovery and now feels that he has the tools to manage anxiety and has even shared tips and techniques with friends. So, as you'll appreciate, this is a fairly recent story, and there are many actions that are going on around this. I think there's 3 points that I would like to make and reflections. The support input from a consistent GP and the periodic welfare checks from Healthy Minds were absolutely invaluable. The rapport was vital in helping Andrew seek help and expose his vulnerability. The option to include pharmacists into mental health neighbourhood teams is currently being scoped to support GPs to feel confident when prescribing such medication. As part of transformation work, we are seeing an improvement to waiting times, and it's important this work continues, as once therapy commenced, it was very effective. The therapist was responsive and supportive, and Andrew now feels that he has been equipped with his skills to avoid a similar deterioration in the future. And finally, people with a long-term mental health condition lose their jobs every year at around double the rate of those without a mental health condition. This equates to about 300,000 people in England, the equivalent of the population of Newcastle or Belfast. We know that employment is one of the most protective factors in mental health recovery and well-being. And I would like to take it back to you, Chair, and thank you for the time to share Annabelle and Andrew's story.
Thank you very much, Kath, and really helpful reflections there, I think, as well. Did anyone want to comment or ask any questions about that at all? Sarah?
You may not know the answer to this, Kath, but I was just interested in the timescale that you were talking about, because clearly that went over the pandemic. So I just wondered if you were aware of any reflections of the difference that made, because we were offering treatment and support, all of us, weren't we, in a very different way. So just interested if you're aware if that made a difference or not.
I think the pandemic definitely did make a difference as far as their own personal circumstances made a difference, obviously, because his wife was shielding, and that increased the anxiety. Whether the access to services was different, I think that's difficult for the patient to explore, and I suppose that's for us maybe to explore within the mental health collaborative. And I know we'll go through the mental health deep dive later, but I think it's an opportunity for us to kind of explore that further, because we do know that people's mental health was affected by the pandemic, and we do know that services were under significant pressure in the pandemic as well. So I think we should take that away, Sarah. And but obviously you chair the mental health collaborative. I think it would be a brilliant opportunity there to explore that further.
Thank you, Sarah. Russell?
Krishni, my point's more generally on the patient and public voice, so I'm not sure if we want to take other questions first before I make my general point. Okay, thank you. I think the other person coming in was Graham.
Yeah, thanks, Krishni. Yeah, thanks for the story, Catherine. I was wondering, you said that the having a consistent person GP was very important. Does that happen in the majority of cases? Or similar situations to this?
Will, I can see you put your hand up. Do you want to come in on that point?
If Kath wants to come in, but I could come in on that point if you want me to, Graham. I think most GPs strive now to establish continuity of care for patients as much as possible. It isn't as easy as it used to be. We are seeing a difficulty with the GP workforce, and we're actually in Herefordshire and Worcestershire, we are slightly protected from it. We have some of the best numbers of GPs per head of population in the country, but even then we are seeing a change in the GP workforce to more additional roles like physician associates, paramedics, pharmacists. To maintain continuity of care because of that is less easy, and it's a shame, because it is one of the few evidence-based things in primary care that stops admissions and actually helps avoid harm. However, what we're moving to now is more of a model where GPs are trying to make sure that patients have as much continuity as possible through the episode of care. So through the period where they have an illness from the start to the end of it, and if it's a chronic illness for the duration of that. It's a changing model of primary care, but it's, I think, a managed change, and I think people are trying to make sure that model is as supportive to patients as possible and giving as much continuous care to patients as possible. It is a difficult one because it's always competing against the access demands. I know there's a couple of other GPs on the call as well if they wanted to come in, but yeah, we are trying to keep that as much as possible.
Thank you, Will. Nigel?
Thank you, Krishna. Yeah, no, that's a really good point, Graham. I think this is actually key. I think the challenge for us, and I think what we're working to is making that continuity of care available where it's important, and identifying actually there's sometimes when it's not so important for people. So actually putting the patient first, asking the question when they are contacting the services, is this something that you feel you would like the continuity of a particular clinician? Using empowering the patient there, they are very good actually identifying, actually this is something that it's a relatively quick fix. I don't really mind which GP I see for this, or actually I've seen Dr. So-and-so, I'd really like to see them because they understand, and empowering the patient I think is really important. That's what we're trying to build into our services.
Thank you, Nigel. That's a really powerful point. I will bring Russell in a moment, but I just wanted to pick up what Kath said about employment for people with mental health, long-term mental health conditions. I know that within the deep dive, there's the reference to the placement service, and I think it's a really important service. But I was just going to make the general point that employment, and this is really a service and an approach that really links directly into the wider determinants point, because it links employment with health, and actually beyond mental health generally. In the days when I used to work in occupational health and wellbeing, there was a report by Dame Carol Black about employment generally, and the importance of keeping people at work, and the importance of that for people's health and well-being. So it's kind of something I think we need to recognise and perhaps can work together, because these are all things that affect all our partners, and we are significant employers across our two places. So how we look after our own employees' health and well-being, I think in the context of that is also relevant. Thank you, Russell.
Krishna, my point was a general point, so thank you, Catherine, for that specific example. But given that this is the part of the agenda on the patient and public voice, I think it's important for us as an ICS and ICB to recognise on behalf of our citizens, despite the phenomenal efforts of all of our frontline teams across primary, secondary and social care, it has been an extremely difficult 4 to 6 weeks for our citizens in gaining access, and I think it's important for us to recognise that as a board, to apologise for our citizens, but also to thank all of our colleagues who have done phenomenal efforts to make the situation as good as it can be. Thank you, Krishna.
Thank you, Russell. Thank you for saying that. I think that's absolutely appropriate for us to recognise that it was a difficult period, particularly in the latter part of December, and indeed I'm sure there will be people watching or who will watch this afterwards who would absolutely have been impacted on by that, and I think you're right to thank the fantastic efforts of all our staff to make sure that we did the best we could in the circumstances. So thank you, absolutely support that, and I'm sure colleagues around the room would do so too. Okay, thank you very much. So we move on now to our strategic update section of the agenda. And the first item within that is the Chief Executive's report. So over to you, Simon.
Thanks, Krishni. Good morning, everybody. So a fairly weighty report with lots of information in. Just to remind board members, we take a decision to try and include everything where we're just updating the board in this report. I mean, it does mean that it's quite long and there's a lot in there, but it also means obviously that we can limit our agenda then when we get past this report to more focused items and where we need a decision or some particular oversight. So that's our strategy and approach with this, and I hope that works for people, but happy to take any feedback. As I said, there's a lot in the report. I don't intend to go through it line by line. I'm assuming that people have read it, but as usual, just to draw out 3 or 4 particular things. So the start of the report covers a lot of work that's been ongoing around our integrated care strategy work, and the NHS planning guidance then that was released just before Christmas includes a number of further milestones, and the report hopefully articulates how we will meet those in Herefordshire and Worcestershire. I wanted just to pay particular credit to and express gratitude to Councillor Pauline Crockett and Councillor Karen May, who chair our health and wellbeing boards. And obviously we've previously decided our strategy will be built on the 2 health and wellbeing board strategies, and Councillor May and Councillor Crockett are doing a great job of leading the local place-based work on that. So the paper articulates where we've got to. You'll see Appendix 1 describes the strategy on a page, which is the high-level summary of that local work and how that translates to our system. And the paper also draws out and describes how we will produce a joint forward plan and an operational plan, which are the other 2 requirements of this work. Moving through the report, Russell just made a really good point around winter pressures. I was on a national call last night, and they are reflecting back on that Christmas period, the middle to the end of December through to about now. There really has been a perfect storm that's combined to create some quite significant demand. We've had I think we've had quite significant a COVID wave in that time. We've had a flu season that I think we probably will reflect on in a month or 2 as being a particularly bad flu season. We've had industrial action. We've had a number of bank holidays in the Christmas period. We've had some cold weather. All of those things have combined to make service delivery really constrained over that period. And I think, credit to system partners, credit to frontline staff, as Russell mentioned, but we must acknowledge just how challenging that period has been. I know when we get onto the report from QRD later in the agenda, there will be the opportunity to pick up on a bit more of the detail. I wanted to draw out on page 5. I know we're having a board development session on primary care access, I think next month, but I wanted to pick out some of the headlines because, as was alluded to in the previous discussion, I think Will said, actually our primary care and general practice access and performance in Herefordshire and Worcestershire really is very good, and it's very good regionally and it's very good nationally, and a lot of these metrics, Herefordshire and Worcestershire general practice stands out in the top 2, 3 or 4 of all of the 42 systems. So we must acknowledge what a good job general practice is doing. I spent a whole day yesterday in a practice in Worcestershire from 7 in the morning till 7:30 at night. It wasn't actually a very busy day, they told me. It was relatively quiet, but it was still hugely demanding and actually hugely impressive, the joined up integrated patient-centred care that was taking place. So some good reflections I hope for the board on that, and I look forward to a more detailed conversation around some more of this at our next development session. And then Chrissy, just to finish, I think from page 8 onwards, just some high-level headline updates from each of the ICS strategic forums that we have that inform our work and our place where we discuss a lot of the big issues. So some really good headline information as to where each of those forums are. So very happy to take any questions on any of those things or anything else in the report.
Okay, can I invite any comments or questions from colleagues? Nothing burning to raise? That's unusual, Simon. I'm
not complaining.
Well, I'll certainly. Oh, Paul Walker, please.
Yes, yeah, thank you, Chris. Thank you, Chair. Thank you, Simon. Good, positive report. Like to see that. Lots of energy and lots of progress set out there. And I'm pleased you recognise the work of the integrated care partnerships. I think the importance of that role and the work that it does to support and deliver the strategic aspect of what we do through this forum is really important to give that profile and presence. And I think as part of that, I just wanted to touch on a couple of things. And we mentioned it briefly in terms of patient story around our targeted prevention work. And I think for me, and perhaps it will come out through the conversations around the forward plan, in terms of bringing together our prevention work across the system. And I think when you link that to kind of the determinants of health and the place-based initiatives and the place-based work that we do around employment, around skills, around quality of housing, and getting that to feature within our place-based work and our prevention agenda is something, you know, I'd clearly like to see coming forward as part of the discussions from here. And I think it touches on all the things that we're going to talk about today and in the future. And I think for me, getting it up our agenda is an important part of the progress that we'll make.
Thank you very much, Paul. I think, David, do you want to pick that up when we come to, do you want to comment at all, or do you want to pick that up when we talk about the point prevalence audit?
I can comment very briefly now, and just to agree entirely with Paul, if you've looked at the strategy on a page that was appended to Simon's report, you'll notice that it is very distinct in its attempts to be long-term in its perspective, looking over a 10-year period, focusing on the actions that we can take now and over the coming years to improve health outcomes and reduce health inequalities. That's going to be driven through a very targeted approach to prevention. Clearly, we've got operational challenges that we're dealing with now, but that strategy is about looking towards the longer term. So, Paul, you're absolutely right. Through the integrated care strategy and the joint forward plan, that will crystallise in terms of our approach to how we will achieve that.
Thank you. And I think one of the things we recognised at the Integrated Care Partnership was the importance of being able to sort of measure our progress as well, which links to the next item on the agenda, but also sort of those metrics that we've been talking about that might be more population health focused than the sort of normal activity related metrics that we would use within the NHS. Sarah, I'm conscious that you may also want to comment on that with the sort of inequalities hat on, but you may have another point, but I'll just bring you in case you want to link to that.
Thank you. No, it was just a quick response to that, really. So that yesterday we had our first health inequalities prevention meeting. Very good there. So looking at personalisation, prevention, health inequalities, lots of work to do to help that group to be a really strategic place where we hold the health elements of what you're talking about there, and how we get that to link well with the Health and Wellbeing Board's JSNA and to fulfil the plan that David is talking about. But really good representation system wide there, from primary care networks through to providers, the directors of public health, and just on your prevention point of view within the ICB, we've a very good and strong member of our team, Emma Fisher, who is a real proponent for prevention and personalisation, and so that alongside the wider view, hopefully through that group, might be an interesting place where we can get that balance right of holding all of those wider determinants, but with this board's focus and health lens on them. So yes, you'd be very welcome to pop along to one of those at any point if you wanted to, but your DPHs did attend.
Yeah, thank you.
Great, thank you, Sarah. That's a really good sort of links through to the things that are going on, and it's really important that I think we're assured that these prevention and health inequalities. You know, after all, they are one of our key duties, so they need to be high on our agenda alongside some of the more immediate challenges we're dealing with. There's a few more people want to come in, so I'll just bring people in the order that they're listed. David Whiteman.
Yes, thank you, Krishni. Mine was only a small point, but just so we don't jump over it. It was on page 7 of Simon's report, just pointing out that the progress that Wye Valley Trust have made. I just wanted to kind of almost formally pull that out again, because it is fantastic progress and a great outcome. So I just wanted to highlight that kind of publicly in front of the whole board, the progress that Wye Valley have made there.
Thank you very much, David, and I can see that Jane is very appreciative of that. Graham.
Yeah, thanks, Krishni. Simon, I'd hate to think I didn't find the question on your report. I just wanted to ask you a little bit more about the delegation of the NHS England functions to ICBs. I mean, it's very close, really, at the end of March. And I was just looking for a general sense of direction, because I know there's going to be a lot more coming on it. But are we really looking at keeping services as they are, or is there a real intent here to transform pathways and make things different for patients?
I mean, yeah, thanks, Graham. That's a really good question. I mean, firstly, it's worth pointing out, so the timetable for this has been accelerated quite significantly. So it was October and then April next year, and it's been brought forward to April this year. So we are up against it a little bit in terms of putting these arrangements in place. I think that decision was linked to NHS England's running cost reduction target that the government have set them, and this is part of how they will reduce their running costs, is by transferring a load of responsibility and staff to us. I mean, my answer would be very much the latter. We do want to transform some of these pathways, some of these services. We have a number of the services that are coming over to us, and particularly dentistry is the one that stands out. Access is appalling, really, and the services coming over to us, particularly in Herefordshire, actually, NHS dentistry is probably the worst in the country. And yeah, we're going to be responsible for that from the 1st of April. So clearly, we're going to want to and need to make some quite big changes in order to improve that position. My concern is that on the 1st of April, the budget we will inherit does relate to what they're spending at the moment. So obviously they're hardly spending anything, because there's hardly any NHS dentistry. So the budget is hardly anything. I am making the point quite strongly nationally that, OK, that's fine. What growth are you going to give us to be able to commission an acceptable level of dental access in Herefordshire? And that point is landing, but I haven't got an answer yet. So I suspect what will happen is our ability to transform and to make improvements will really be directly linked to the resourcing that NHS England associate with this. So once we've got that clear, I'm confident we have the capability, I'm confident we have the capacity, I'm confident the arrangements we put in place will be able to deliver that. Yeah, but it is going to need resourcing. The dental contract, needs an element of flexibility in it, and to buy more NHS dentistry for patients in Herefordshire and in Worcestershire, where access is better but still far from what we would like, we're going to need to allocate more funding. I mean, there is a point probably for the board that if we eventually don't get the funding we need, it's a question for us: do we use some of our money to put into dentistry? I don't know what the answer to that would be. Certainly we have a number of different calls on our money, don't we? And that would have to be added to the list. But ideally, we will get an appropriate budget to deliver an appropriate service to our population. So I think that's the crux of the debate for the board over the coming months, is to see and to challenge me on how that process is evolving.
Thank you, Simon. And certainly, I think we recognised some months ago when I think I recall attending a health and wellbeing board where we were talking about access to dental services in Herefordshire at the time, but it is a particular challenge for us, and actually, I couldn't help noting that the later report that we have that relates to the Herefordshire Children's Services also talks about access to dental health for children in care or care leavers. So dental health is a potential inequalities issue as well, isn't it? And or oral health, and so isn't it really one that we need to think very carefully about? And Simon's challenge is a good one. In that, you know, if whatever we are responsible for, we will need to make some decisions as a board as to where we wish to prioritise and invest, and this may be an area that we will need to look at together. In the meantime, I think there is a sort of process of due diligence still underway, isn't there, Simon, that will undoubtedly be looking at this whole delegation and transferring the pod services as it's referenced. I also just wanted to reinforce the point that Paul Walker made just regarding the value of the integrated care partnership assembly. It's a really strong body with incredibly well represented across our whole system, albeit recognising the primacy of the two places in terms of the two health and wellbeing boards. And thank Councillor Crockett and Councillor May for their leadership of that. And I know, you know, I did promise that I would emphasise to this meeting in public that the important value that offers to us, and the recognition that it really does bring partners together to work together to develop our longer term strategy. So thank you on my behalf as well. Okay, we now have item number 9, which is the point to prevalence audit. And I move on to David Mahaffey, please.
Yeah, thanks, Chair. Just before I do that, just wanted to just update a couple of things. In Simon's report, there was mention of the next ICP meeting being on the 15th of March. Just to clarify, that's likely to be moved into April because of some changed timeframes around development of the joint forward plan. So just wanted to highlight that. And also, Christian, you mentioned about key metrics and really being able to measure the impact of the work we do. At the March board meeting, we'll bring a kind of a 25-30 page more detailed strategy to underpin the strategy on a page that will outline those very clear metrics, and there I can confirm they are very much aimed at sort of population health measures and long-term improvements rather than the kind of core operational delivery measures. So just moving on to the point prevalence audit then, you'll recall that we had I brought some initial findings on the point prevalence audit to the November meeting, and that we said that we would bring back some more details to this meeting. So you'll have received the report. Just want to highlight a few key points from it. Just to remind people that there was a strategic steering group set up to oversee the development of the methodology and the delivery of the work, and the early part of the report outlines who those members were. For me, that worked really well, having that strategic steering group, because what it did was it gave us buy-in across all of the organisations, senior leadership to drive the process forward. And I don't think we could have delivered the point prevalence audit in as a smoother way as we did without that senior leadership. So appreciation to all members of the senior leadership group who are represented in that report. And just like to also emphasise it was built on other methodologies, particularly the methodology that was developed in South Warwickshire. So appreciation to Russell and his group of hospitals there for sort of developing a method that we could build upon, and that gave us a good head start in doing this work. We had a 3-month lead into this work over the summer, which enabled us to properly, really be prepared for it, to train the staff in the delivery of the methodology, which helped it go off without a hitch. And I mean, it really did go off very smoothly. Top of page 3 just highlights the fact that we looked at 1,800 patients across 83 different care settings, and the report there just kind of shows the settings that was undertaken. So you can see it's acute hospitals, community hospital beds, community pathways, community teams, and we did it across physical and mental health services. Top of page 4, I think, was important context going into the date of the audit, which was Wednesday the 21st of September, just shows the kind of 3 days leading up to the audit in terms of ED attendances, admission numbers, ambulance conveyances, things like that. It also highlights the number of decisions to admit that were being held in ED at the time of the audit, and include some information on something called the criteria to reside, which is a measure of kind of appropriateness of hospital beds. So all of that is important context leading into the audit. So what did we actually find on the day itself? So what we found was that 24% of patients of the patients we looked at could have been cared for in a more appropriate setting for their needs at that particular point in time. Now, typically, those settings would have been what we call left shift settings, so a cheaper cost setting. So not treating people in acute hospital beds if they could have been in community hospital beds, not treating people in hospital beds at all if they could be treated at home with the support of community teams, etc. So overall, it was 24%. And bizarrely and coincidentally, it was almost identical in each of the two counties. So 23.97% in Herefordshire and 23.98% in Worcestershire. That is just coincidence. I've double checked, triple checked and quadruple checked all the figures to make sure that I've not calculated that incorrectly, but it is correct. But what you'll see on the table at the bottom of page 4 is the very different profile across the two counties. So we can see what I would describe as much greater backdoor pressure in the Herefordshire system, so greater pressures on the social care system. But in Worcestershire, it seems to be much more in the middle of the pathway, particularly evident in community hospital beds. So there were more, a greater percentage, almost what 40%, 41% of patients in community hospital beds that could have been treated in community settings in their own home if we could get that care in place. Clearly, this is a measure of flow, and flow affects the position in acute hospitals, and it's important to identify where those issues can be unpicked. And sort of page 5 provides a little bit of information there on the detail of it. I won't plan to go through that in any more detail than it's shown there, but I would like to highlight that the audit wasn't an end in itself. So the fact we've done it, completed it, reported the results, doesn't mean that we put it to bed. It's an absolutely fundamental part of our strategic planning process. So board members will probably recognise the questions that we tackled at the last development session around strategic choices. There were lots of questions about left shift, investment in prevention, tackling health inequalities differently. Those have all been driven, those strategic choices, from the sort of data that we've collected during this point prevalence audit. So it's something that will be a theme of our strategic planning process going forward. You'll see reference to it in the joint forward plan when you start to see the drafts of that, and you'll see reference to it in other action plans that we implement through the operational planning process. So the bottom of page 5 kind of just describes the next steps, where I've sort of outlined the reference to the strategic choices. The next piece of work we're going to do is some peer review, where operational teams across the two counties will review each other's work and support each other to share good practice, identify opportunities for doing things differently, and develop that in a kind of safe peer review space. So there's not a kind of feeling of being done unto, but develop the ideas themselves. We have done some work to look at the health inequalities that emerged from this, and there was some correlation between deprivation and the likelihood of people being in the wrong care setting at the point in time. Not significant, but we're going to do some more work to understand that in a little bit more detail. And then the final big piece of work we're going to do as part of the joint forward plan development is to commission some strategic demand and capacity modelling across the whole system. So if we can see from this point prevalence audit that we're not treating people in the optimal care settings, what we need to do is have a very clear strategic model to tell us what that optimal care setting model should be, so we can move to that over the period of the next 5 to 10 years. And it's that point that I'll just end on to emphasise that, as I say, we don't see this as an end in itself. We will be planning to replicate this audit again on the 3rd September, on the 3rd Wednesday of September this year, and every year during the period of the point prevalence audit, so we can monitor whether the implementation of actions we are taking to address these issues is having any effect or not. And if not, we can help to understand why not. So I think I'll pause at that point, Krishni, and happy to take any questions.
Thank you, David. Okay, I think there are some questions or comments. So first of all, Simon.
Thanks, Christian. I just wanted to add, I mean, I think this is a really good piece of work, and I think we commented on that before, and it's really useful in driving our strategic approach. What I want to do is to use it as a stepping stone through a number of other things I think we need to do this year. So there's a lot of prominence in the national planning work around demand and capacity, i.e. a very accurate and proper understanding of demand now, what we think might happen to demand over the next year, 3 years, 5 years, 10 years, and critically what that means for the bed capacity we need, both in the acute sector and in the community sector for people rehabbing, and in the discharge pathways, and actually potentially in the wraparound care that potentially prevents people accessing some of these services. So I see the point prevalence work as the first stage in a longer process where we need to do some much more detailed modelling work to understand what it means. So I just wanted to flag to the board that really I hope that certainly by the May meeting we're in a position to feed in some of that demand and capacity work, because I think that's critical really for us strategically moving forward.
Thank you, Simon. There's a lot of comments or questions to pick through, so starting with Sarah Dugan.
Thanks, Krishni. I really welcome this work. I think it's really, really helpful. I just wanted to clarify though, David, in the next stage of the work, if we could draw out the care home dimension a bit more, because community hospitals is down as 96 patients could be in a care setting, but we normally run between 30 and 60. So I'm not sure from the heading, Community Hospitals Pathway 3, whether that includes the intensive assessment beds and some of the nursing home capacity, but it would be really useful to do that in future work, because when we've previously done modelling, and many years ago, it was actually quite interesting to look at the NHS bed base and the nursing home provisions side by side. So just a request, David, I don't know if you can comment any further on that, or whether we could think about that in the next stage of the work. Thank you.
Yeah, it was so it was all the community hospital beds, all the specialist community hospital beds, and any patients that were in either block purchase or spot purchase pathway 3 beds in care homes.
Thank you. It's just important to say, because I think you referred to people who could be at home, and I think a large number of those people are actually in or heading for nursing home care. So it was just so we were clear on that. Thank you.
Thanks very much. So I'll bring David, I think just in the interest of time, because we've got quite a lot of questions and comments, I probably won't, and colleagues, I probably won't put every single question to David immediately. Let's get a few people kind of commenting and raising questions. So David, I'm going to need you to make some notes so that you pick these points up, but I'll bring you in maybe after a few, so just in case there are any questions that you can respond to immediately. So Nigel, I'll take Nigel, Jane, and then Vicky. So Nigel first, please.
Thank you. Yeah, really good piece of work, I think, really clear. I just bringing things bang up to date. Obviously, systems have just been informed about increased funding for the interface into social care and moving there. And so my question really is, what sort of reasonable changes can we expect? And can we be updated on the impact that those have on our system?
Thank you, Nigel. Jane?
Yeah, I might speak to that a little bit, Nigel. So a great piece of work, as you say, and as you say, something we did in Warwickshire over a number of years that really helped to guide the blueprint for what sort of capacity we needed everywhere. I guess my point really was, though, I don't want there to be a sense of, we're just starting this work now, and this is part of what we're already doing. This is the what's guiding the work that we're doing as part of One Herefordshire in terms of the BCF and funding, and how we're redesigning the D2A pathways, how we're making sure the capacity is right. More importantly, actually, how we're making sure that the process is right, so that people flow through those pathways rather than get stuck in another place. So that is part of that wider strategic review of D2A that we're undertaking in Herefordshire, and I'm really excited about that work. I think it's going really well. And I guess the other point I would make, which probably goes back to the very beginning and the question from the public about PJ paralysis, because of course the best thing we can do is not get particularly frail elderly people into hospital at all. So the flip side of this is all of the work that we're doing under virtual ward urgent care response teams, so that actually we're trying to prevent people going into hospital in the first place. So I think this speaks to a wider set of transformation that's happening. And obviously I can only speak to the Herefordshire end of that.
Thank you very much, Jane. And finally, Vicky.
Thank you. I think just linking some of those points, in Simon's report, he was outlining the strong out of hospital offer, which is fantastic. But in the point prevalence work, obviously the pathway 2 numbers in terms of the restrictions on that is a fairly strong inhibitor for being able for patients to be able to progress across their pathways. So just wondering really in terms of the repeat of the point prevalence, how quickly we're going to be able to take action to resolve some of those restrictions on pathway 2 in order that we make a difference next time we undertake the point prevalence in September.
Thank you, Vicky. David, are you able to comment on any, or do you wish to comment on any of those points? I know Jane sort of partially addressed what Nigel said, but do you want to comment on that?
Yeah, I mean, specifically Vicky's point, I think is an important one to start. I think our starting point on that is to understand whether it is a demand or whether it's a capacity issue. And there was a sense amongst the strategic steering group that we may, as a system, have an inherent preference, if that's the right word, to putting people on pathway 2 when potentially they could go on to pathway 1. So therefore, it might be that we're overloading our existing capacity with excess demand that could go straight out, because one of the issues that the audit showed was quite a few people in pathway 2 settings that were waiting for pathway 1 assessments. Now that might be because it's a natural part of the pathway, or it might be that actually it was the easiest way to discharge people from acute settings, and then they needed to have their assessment that they could have gone straight home if we'd had our process right in the first place. So there's a little bit of further understanding that we can do before we conclude that it is a capacity issue, which is the importance of this strategic bed modelling work we need to do.
That's really useful. Thank you, David. OK, let's take a few more then. Same approach, David, if you wouldn't mind. So Nikki next.
Yeah, this was going to be my point. I think that you need more narrative than just the numbers. I think this is about planning earlier in the patient journey when they arrive in hospital. Because just being in the wrong bed might just be that you didn't plan early enough for the discharge and then they haven't gone to the right place. So the numbers really about, is it about the sort of clinical leadership about the planning? Is it about maybe the social setup, the family ready to receive the patient, all of that, the patient just mentally getting themselves, prepared for leaving hospital. And then whatever's happening on the weekend is always an issue when people are in hospital. So I think it's about, as soon as you come into hospital, having in mind what's going to happen when you go home, and the narrative needs to be attached to this report about almost identifying why they were in the wrong place. But that's because the planning needs to start earlier, so that adding much more narrative to this will make it a richer report to get people to the right place quicker. Thanks.
Thank you, Nikki. Paul Walker.
Thank you. And yeah, as others, really appreciate this piece of work that's coming through and look forward to the report, which is going to come back to us next time around demand and capacity. I suppose I had a question kind of looking at both the strategy and the kind of the operational. I understand the demand and capacity report will come back in May, and that's a focus of attention and will repeat in September. But just thinking about the kind of the 24% of patients who were stuck in the system, what happens on to unstick that and move that on the day?
OK, thank you, Paul. So I'll just let David reflect on that, bring Sarah Raystrick in, and we can get a comment on that afterwards. Sarah?
That's just a quick point. Understanding this is about flow and capacity and demand. I just wonder whether when we do this again or when we look forwards, whether we can capture within the methodology patient or patient and carer perspective on whether they believe that they're in the wrong setting, because I think that might also it may give more numbers of people who believe that they themselves could be in an out of hospital setting, and might just add something else for us to think about there. Thanks.
Thanks, Sarah. I might bring Aman in as well, just because. Oh, and there's Russell actually. So no, let's get David commenting on those. Otherwise, there's too many for David to remember everything and too many notes to make, I think. So David, if you want to comment on any of those points. Yeah, I'm going to recruit some help for some of these questions. I'm thinking Mary might be the best person to comment on the flow. So what happens to the sort of 24%? I've got views, but I think Mary's a little bit closer to the operational detail. So before I come on to that one, Nikki's point, discharge planning. Yeah, I mean, I think it goes without saying, doesn't it, that if you're planning for somebody's discharge on admission, or even before admission, if they're coming in for elective care, then that's going to lead to a better and more optimised system. One of the things that struck me on this audit itself was the data around criteria to reside on page 3. So the significant difference between criteria to reside numbers and medically fit patients in Worcestershire, but the distinct similarity between the two numbers in Herefordshire. So we want to try and explore through the peer review process what might be driving that, and does that influence the way in which discharges are managed? Is it reflective of a different way of working, or did it just happen to be something that was unique to that day? So the other point about Sarah's point about capturing patient and carer's perspective, really interesting thought to do that. At the moment, I'd have to think how we would do that, and Jane and Matthew might be better placed to think that. Jane particularly, because you're obviously much closer to this, but an interesting thought that we'd have to think clearly about how we could implement the process to do that, because it's quite difficult to get that volume of information captured, but we can come back to that. So Mary, the 24%, what do we do operationally today to try and unblock some of those issues?
So I can speak more for Worcestershire, but I'm sure Herefordshire have a similar process. Worcestershire has a 7-day-a-week discharge cell, it's called, led by a senior clinician and all the partners together in a room for about 2 hours a day. It's a long process. They go through every single patient that needs a complex pathway or think needs a complex pathway, and block the myriad of things, be it family choice, family engagement, patient wishes, all of those things, all the equipment they need, everything they need to get home. I mean, a lot of us on this call have been and sat in these discharge cells, and the challenge is quite significant. But the complexity does feel definitely higher than I've noticed before. So there is a drive for home first, there's no doubt about it. You know, there has to be a very high bar to go into pathway 2 or 3. But it is a daily challenge operationally that the teams do at a very senior level to make this happen.
Thank you, Mary. Okay, last few comments, and I think we will need to close this item. So Aman first, then Russell and Anita. So Aman.
Thanks, Krishni. My point was similar to Vicky's, but just building on that. I know there's lots of really good work happening, and there's lots of reviews and things happening. It was just a sense of, you know, there might be interventions that we need to put in place as a result of those, the result of that work that's happening. So do we have any idea of timescales, given that you're looking to repeat this exercise in September? So just a sense of what's realistic in terms of impact and how we're, you know, I just wanted to get a sense of that really, because I don't know how long some of these things are going to take and how, you know, what the interventions needed are going to be.
Okay, so a sense that how we're going to impact in the time we have available to make the change. Yeah. No, it's a good question. Thanks, Alan. Russell.
Just a few quick points from me. First of all, thank you, David, and everyone involved in doing this, because it wasn't an easy thing to do. Secondly, if you do the math, this is an enormous opportunity for us as a system, and given our financial trajectory, we have 3 big opportunities as a system. One of those is the point prevalence left shift work. The second is the enormous cost of agency, and saving on the profit that the agencies are taking out of our system. And the third is the girth and productivity work, which Marie's doing such a great job on. On this, though, we are already doing good stuff. And I'm sure Jane and Matthew and others can talk about the good stuff we're already doing. But we mustn't lose sight of 24% of our patients who are in the wrong place when you do the point prevalence work. So we do need to think about this in the long term, because if it was easy, we would have done it already. But the level of savings, which we can then reinvest into primary care and prevention, is a wonderful opportunity for this system. So I really do hope that we build on David's work and keep it at the forefront of our minds of where the opportunities are.
Thank you, Russell. Anita?
Yes, I mean, part of mine was actually what Russell has just said. I do think this is an excellent piece of work, and certainly our thanks to Foundation Group for having sort of helped us do this, but I think the team have done a really good job. Just one sort of observation, I guess, more than anything else. I know looking at the data for Worcestershire, it looks like Sarah and Mark have got a serious problem with the pathway 3s, you know, the sort of the 96 beds there. An observation is, I mean, if you like, your prima facie thought would be, it must be that we don't have enough care home beds, and that may well be where the research goes. But it does occur to me that part of this might be about functional decline caused by the overall length of the pathway, that patients are in some sort of care, and that would be both acute and community. And I wonder whether going forward, for the complex pathway patients, actually keeping track of the total pathway across both acute and community might be really helpful, because my guess is if our overall length of stay across the pathway is increasing because of functional decline, it's going to force more people towards pathway 3 and needing care beds. So really, you know, look forward to seeing where the research goes, but I wonder whether there's something about how the whole pathway is working that is possibly leading to you know, us perhaps thinking there's a bit of concern on pathway 3 beds. Thanks.
Thank you very much, Anita. David, do you want to make a final comment?
Yeah, I will. Thanks. I'll go just back up the list of things. So Anita's point, I think it's a really good point about functional decline and long pathways, but I would also just go back and emphasise the point I made earlier about we shouldn't jump to the conclusion that we haven't got the right capacity, because it might be that we're not using the capacity in the right way. So part of the process that we've got to go through is to make sure we've got that optimised balance right, because there is a sense, and I say it is only a sense, and Jane might want to add some thought to this, that unless we make the easiest route out of hospital the right route out of hospital, or the other way around, the right route the easiest route, then there's always a risk that people will, in times of extreme operational pressure, will go out on the easiest route rather than the right route. Now, generally speaking, the easiest route is if there's empty community hospital beds, that's easier than some other routes. So I think we've just got to bear that in mind in the work we do. Russell's point about not losing sight of the 24% and the level of savings, I mean, yeah, it's critical. We've got to build that into our strategic planning process, and I think that's quite strongly linked to Aman's point as well. There's some very immediate operational learning that we're doing. So the peer review, and Mary might want to mention the work that's been happening in Worcestershire on the Ops team review, the onward care team review, and some of the operational learning around that, which will help us implement change. But there's two distinct challenges for us. There's the strategic difference, the strategic change that we can make over the longer term by getting the capacity in the right place. And then there's the operational challenge that we can get in the short term, which is over the coming weeks and months of making sure we use our existing capacity in the most optimal way now. And I think for September, the first thing, absolutely, we can get right. The strategic change about getting the right capacity in the right place probably is a slightly longer time frame. And it's probably the first few years of the strategy rather than the first few months of the strategy.
Thank you, David. Mary, do you want to make a final point just on, I think, the sort of immediate operational opportunities? I know you've already talked about the discharge cell, but David mentioned the onward care team, which is another area.
That's right. So we Onward Care team has just finished a review. One of our ex-chief nurses come back in and done a review based on best practice. Very detailed outcomes, and which shows some immediate things we can do to improve and take steps out of the pathway, because we know there was far too many steps in the pathway. So the COOs are meeting tomorrow to decide the actions, timescales, and what we can do quickly. So happy to share the back with whoever's interested after we've concluded that tomorrow.
Great, thank you, Mary. And thank you to everybody again who was involved in that. I mean, it's a really important piece of work, and I think does give us some really valuable insights and a basis for immediate improvements and longer term improvements, which David has highlighted. So really at this stage it's for us to note the report and the actions that are in hand. And clearly there's a range of actions that will also feed into some of our longer term planning. So I just again want to thank people and all the partners really who were involved, because it's no mean task to do this across the system on a given day, and very helpful. So thank you. Before we get into the performance focus section, I suggest we take a very short break just to refresh our cups of tea or coffee, and start again in 5 minutes, if that's okay. And then I think we can crack on to the end and cover all our the rest of our agenda. So if I can ask you to be back promptly in 5 minutes, please. Thank you. Okay, welcome back everybody. So if we're ready to kick off with our item number 10, which is a bit more of a performance focus, and we have a deep dive today on mental health, and I think Sarah's going to lead it as our official representative regarding mental health on the ICB. So over to you, Sarah.
Thank you. Yes, I'm leading the report as the SRO for mental health. As you know, my interest is declared already as Chief Exec of the Trust. Jenny Dalloway is also going to join the meeting. I think she was here a minute ago, so I presume she'll be back, who is the Programme Director for Mental Health, and just express my thanks for her to preparing this paper. You'll see that the paper is very broad in scope because it covers the whole of mental health services, so it may be that the ICB in future wants to take a deep dive into one particular area rather than try and cover all of the programmes of work, but I'll leave that up to the group to decide. So given this is the first meeting, it's giving an overview of all of the programmes and progress of the Mental Health Collaborative as it stands for your attention. I won't go into huge amounts of detail, but because of the range, I will just draw out quite a few key points. So I think the board is aware, I think everybody on the board is now aware of the Mental Health Collaborative, which has been running in shadow form for over a year now, hosted by our trust, but that's very much from a governance perspective. It's very much a partnership where there are joint conversations and joint decision-making processes built into the way we work. We report as a collaborative into a number of places. We report to the ICB. We also report into the Health and Wellbeing Board, and we work closely with the Health and Wellbeing Boards and really appreciate their interest in and prioritisation, I guess, of mental health and wellbeing in their strategic priorities. We also report into both places, and I think it's really important to say that because the work of the collaborative is about looking at where we can collectively work on mental health programmes of work and particularly the national priorities, but it's very much a case that we need to work with and reflect up and down in terms of priorities with both of the place boards, which we do. You'll note in the paper that up until now, the oversight of the mental health programme of work has been conducted by NHS England, and we have attended as a trust and as an ICB from a commissioning and planning point of view. This process is now transferring to the ICB, and Jenny Dalloway as programme director will lead that oversight work with NHSE attending moving forward, so that's quite a shift. You'll note in the report it asks the board to support a review of the governance arrangements, and I just wanted to explain this a little bit more. So we've moved from a process where each agency has got their own groups to manage the programmes of work, and what we've now got is we've reviewed our structure and particularly the subgroups of the collaborative to make sure that all of those groups are multi-agency and that all of the information, performance, quality issues are starting to feed in through one route. So there's a sort of sub-governance structure, if you like. The other thing that's noted in the report is joint committees, and we haven't got to the point yet of asking for a specific decision from the ICB. What we're doing is we originally planned to delegate the full mental health budgets and functions to the collaborative in April of this year. But as you will all know, the national guidance and rules and proposals around delegation of functions from an ICB have continued to emerge and evolve over the last year. So one of the options in that scenario is to look at a joint committee between the host and the ICB, and that's something we want to explore, but at the moment it's just at a very early exploration stage, and we would intend to come back to the board with the outcome of some of those conversations, but it's just to raise it with you now. You'll see from the bottom of page 3 onwards, we outline the work programme of the collaborative. It's largely based on the National Mental Health Work Programme and the long-term plan deliverables for mental health, which are outlined for you there. The next section is performance, and just a couple of key points because I don't want to walk through every single section of this, but there are two key issues, I guess. One is to give you the assurance that for all the areas of non-performance there are recovery plans which are overseen and monitored by the Mental Health Collaborative. And also just to note the impact of the Care Notes national outage. So you will be aware that we were subject as a trust or impacted on by the cyber attack on a company that provides clinical systems to the NHS, which included Care Notes, which is our electronic patient record. Care Notes went down nationally early August last year. We've been without it for a long time since, and this has really affected our ability to monitor performance. As you might imagine, we've had an interim solution in place, but it's not as effective as the full system. I'm pleased to report we've got the full system back now. It's finished testing, and last week we started loading teams back onto it. So by the end of January, we anticipate that 50% of our teams will be back on the system, but it is having a big impact on our ability to monitor our performance in a sort of detailed way. So just to make you aware of that, because you might be wondering, why is some of this data June and July as opposed to November? So that is part of the reason. So just to draw out a couple of key points, the first one is the improving access to psychological therapies, which is one of the areas that we have been struggling with. There's two issues here. One is that the national targets were changed about a year ago, and the current workforce we have or staffing funded complement to meet the new national target is not going to attract that level of activity. So there is a gap in terms of the workforce we've got compared to the target we're now required to deliver. So we're doing a big transformation programme to see if we can be more efficient and effective in how we deliver that. The other key workforce issue is that the workforce for the new target to be delivered, a number of people have to go through formal training, which is quite long. So that means that we've got people in training who can't actually deliver activity yet. So just to focus on that. Obviously, during the pandemic, we've shifted to a lot of online digital training options, and we have seen a slight dip in the recovery rate in October and November. So we're just doing a review at the moment about the modes of treatment and the types of therapy to see if there's anything we can glean from that. The other thing to note in terms of the data is that the data is calculated at the point of discharge. So we are actually seeing quite a significant improvement from the transformation programme, and we have in the last couple of months actually delivered on the 6 and 18-week targets, but they don't actually show in the data till the patient has finished their treatment and been discharged. So just to draw that to your attention. The other thing that's important is because we have a gap, we have a waiting list, as you know, and we have a gap in the number of people we can treat. So to support that, what we've done as a collaborative is we have taken some of the resource available for IAPT, and we have gone out, if you like, to PCNs and the voluntary sector to see if they could undertake some joint projects that would really help patients who are waiting for the full Healthy Mind service, or possibly support patients who may not then ultimately need that service. So some really exciting and innovative projects going on to support a greater primary care and voluntary sector input into this space. You'll be aware that the national targets and the IAP model is quite specific and quite strict. So Region are quite interested in how we progress with this, because it is of note nationally if this is successful. So my thanks to PCN and VCS colleagues for engaging in that so actively, and we will report the outcome of that in due course. But as you'll note in some of the asks of the ICB, one of the recommendations at the end you're asked to support is that shift of resource to support a broader offer. I just want to draw out dementia diagnosis because it's another of the targets that we've continued to struggle with, and we're achieving 52% against a national target of 67%. This has been at this level for some months, and it is to a degree we are concerned it's stuck, and despite all the efforts that are going in, we seem to really be struggling to shift it from the 52%. The latest project we've got to improve this includes an introduction of a diadem, which is a clinical tool, into nursing homes, and to try and roll out support to nursing homes to see if there are people in nursing homes who've not been formally diagnosed. And that's just started. Staff have been employed to do that, and that's just started. The thing we're asking the ICB to support is that we're going to implement the Living Well with Dementia pathway, which is a national model working with the dementia partnerships in the county. And I would stress that we have got phenomenal support for this programme of work from all partners and local communities. There's real engagement here, which is why it's partly disappointing the target hasn't shifted, but we've got some really fantastic work going on with lots of partner engagement. I just wanted to pull out then the out of area placements, because we've always historically as a county performed really well on out of area placements, but for the last probably 4 or 5 months we have had more patients out of area. We know that this is not ideal for patients. It's really real priority for us to repatriate patients back to the local area where they can be near their friends and family, but we have had an increase. Some of that is related to the availability of intensive care beds. We have intensive care beds on the Worcester site, but we've had such a demand for intensive care capacity. This has been one of the key drivers for individuals receiving their care out of area. So just for you to be aware, there is a West Midlands mental health provider collaborative, and one of the areas we're working on as a West Midlands collaborative is looking at the capacity and demand around psychiatric intensive care beds, so that we can see if there's an alternative model we can support in the NHS that is closer to home for all of our patients. So just to note that. And I wasn't going to comment on page 11 on individual placement support, but it was mentioned in the patient story and Krishni drew attention to it. So just for your information, the placement support is aimed at people who have experienced a mental health need or crisis and would like support to get back into employment. It is a targeted programme. There's a national model and guidance that drives it. And we have 2 services. The Worcestershire service is provided in-house by the Health and Care Trust, and the Herefordshire service is provided by a voluntary sector provider called Landau. Really great service, and we've heard a number of patient stories at our board about what a difference this has made. We all know how important it is for people to have an income and employment and give them a sense of purpose and well-being, so it's a really important service and one that we are exceeding our targets, and there is potential for further focus. On page 13, I just want to draw out the suicide prevention work. There's some amazing work going on led by both public health teams across the 2 counties, and it's funded through the Mental Health Investment Standard, which I'll touch on in a minute, aimed at rural populations and middle-aged men. So it's led by public health with support from our comms teams to really promote actively with local communities what we can all do to support our local neighbours and communities to reduce the risk of suicide and give people appropriate support and signposting. Urgent care mental health is covered in the paper in regard to particularly the 111 situation, and also to do with the urgent mental health crisis line. You'll see a range in the paper of some of the offer that's provided. The key focus at the moment in terms of long-term plan deliverables is about what the project which people refer to as mental health in ambulances. So it's about the ambulance service redesigning some of their pathways with us as partners to look at how we can provide a better experience for people who have urgent mental health needs. So that is outlined in the paper. You'll also see a quantification of the scale of calls taken by the crisis line, which is about 2,700 a month. It's just over half of those, 58% of those calls from patients, 42% from professionals who are then supported, signposted, and the patient is contacted where appropriate. We have had a number of more ad hoc concerns raised about the crisis line, which we are currently jointly looking into to find out how else we can improve that service for patients. So just wanted you to note those priorities around IAPT dementia, out of area placements, and it also notes the physical health check for mental health, support the dementia pathway, and also look at the note around the work we're doing around the urgent helpline. There is an outline in the paper of the mental health investment standard and the financial position, and we are overachieving on the standard. You'll be aware the standard is a minimum investment required for mental health, and we have delivered well on that. We do, however, have some cost pressures which are causing overspends currently, about Section 117 aftercare, which is aftercare for people who've been admitted to hospital under certain sections of the Mental Health Act who need aftercare support, and the out of area placements, which I've mentioned. You'll see on page 15, and I did want to draw this out because I think this is really interesting in the ICB context, but the collaborative has done a lot of work led by Jenny around developing a collective risk register for the system for mental health and wellbeing. It hasn't been easy, I think it's fair to say, because we all have quite extensive risk registers. We all have slightly different ways of grading risk. So the first point of call was to agree on what we thought the key risks around mental health programme were, and you can see the 5 key risks outlined in the paper. But the second point was to try and get collective agreement on the scale of the risk and what the collective risk level looked like. So the key risks are workforce retention and recruitment is the highest risk for all partners. We know we've talked about the workforce challenge significantly, and I'm sure Katie will be able to comment at some point, but the biggest thing that's an issue for us now is filling vacancies. We do have a lot of funding for some of these service improvements, but we can't actually fill the vacancies, particularly around registered mental health nurses. So the ICB has supported the system with some workforce planning roles, 3 workforce planning roles, to really help us look at this in more detail, and there is a workforce planner who will be allocated for mental health, which will make a huge difference. So you'll see from the risk register, it's workforce retention and recruitment, some of the cost pressures I've mentioned, the increasing demand, the capacity to support children and young people, emotional wellbeing, and delivery of the long-term plan priorities. So those have been agreed by all partners across the system as the key risk. The report notes the CQC report to Hillcrest. We still haven't received the final report to that, and we'll obviously report through the quality committees when we do. And then just to note on the coming programme for the coming year, it refers in the paper to the proposed change around Athlone Ward and the hospital at home service for older adult mental health. That's of real note to the ICB because the ICB will receive a business case in March regarding that change to be considered. So this was a change that happened suddenly in the pandemic where we were required to release additional beds at a point when we weren't sure how many beds were going to be required to support COVID patients. And in that period, we suspended the service in Athlone Ward, the older adult mental health ward, or one of them. We have some more in Bromsgrove. And we set up very quickly an older adult mental health hospital at home service, particularly to support people with dementia. That service has been hugely successful. We've done a number of evaluations and patient feedback. There was a concern that carers would be concerned about it because it would take away some of that inpatient option. But actually, carers and family have evaluated the service really, really well. But we have to go through a formal process to make this change permanent, as you'll know. So NHS are involved, further consultation is happening, and it'll come back to this board in due course. And just finally to say, we have a meeting of the collaborative tomorrow. We're starting to review the planning guidance and the priorities for the coming year, look at the available resource for the mental health investment standard and collectively agree what we think the priorities are. So the first part of that conversation is tomorrow, and the recommended priorities will come back through the ICB when the collaborative has done this piece of work. So sorry to talk for a long time. There's a lot of elements in this report, and as I mentioned at the beginning, Jenny has joined us if you wish to direct any questions at Jenny as well. Thank you, Krishni.
Thank you, Sarah. That was really comprehensive. Are there any comments or questions that people would like to raise regarding the content? Vicky.
Thank you, Sarah, for the report. And obviously we received a detailed mental health deep dive at QRD from Jenny. So with both of the reports, I've learned more through your report as well. So that's been really helpful. I just wanted to pick up the point about the voluntary care sector and the positive move to get their support in terms of early intervention. And I just wondered what support you need from the ICB or the ICS in terms of amplifying whether there's any lessons learned in terms of the positive use of the voluntary sector.
So in the collaborative in general, there's strong representation from the voluntary sector, particularly from Onside and Mind in particular, and they're really engaged in all of the collaborative conversations and decisions. The specific I mentioned was related to the gap and the waiting list around IAPT, where we're doing some specific projects. So I might just draw Jenny in, because it might be helpful just to give you a few examples of the sorts of things that people are doing, because actually it's really exciting and definitely the way forward. For them to be more integral in our offer. Jenny, I don't know if you want to give a few examples.
Yes, thank you, and morning everybody. So in terms of the IAPT offer, what we found is a number of individuals were being referred for IAPT, but actually they probably weren't going to benefit from the clinical intervention that was offered. So working with PCNs, all have identified, and this is where we think it's a really positive move, actually local providers within the PCN who can deliver that support locally. So we have a range, some are actually providing clinical interventions as an absolute alternate to IAPT, and others are working with their voluntary sector colleagues really around some of the social determinants. So I think some of that was coming through in the patient story, wasn't it, where people are actually concerned about employment finances, those sort of things that actually that needs to be addressed, and then it may be that the therapies are not required, or maybe clinical interventions are. So yes, it's around really where there are those local relationships, which we think is really positive, and they are trusted providers. That's the other thing. So I think we have some specialist mental health VCS providers, we have some non-specialists, but they're all trusted by the local PCNs and have been working, and in some cases are already providing things like social prescribing. So they are known to the practices and trusted to provide that support.
Thank you. Thank you, Jenny. OK, there's now a little sequence of questions for you both. So just if it's all right with you, Sarah, I'm going to take a few so that we, if you wouldn't mind making a note if there's anything you can respond to. So first of all, Sarah Raystrick, please.
Thanks. Just picking up on the point about dementia diagnosis, and while I would share your disappointment and frustration at the rate of dementia diagnosis, I just wanted to pick up on the point you made about your positive assurance about the provision in place for people once they do have a dementia diagnosis, which I think actually is a more important marker. So it was really just to ask, are you positively assured that, as this is a meeting in public, that should members of the public be concerned about a dementia diagnosis? I know sometimes the question is, well, why bother? What can anyone do about it? That in Herefordshire and Worcestershire, if there were an early diagnosis of dementia, then we would be able to offer positive and practical support to both the patient and their families. Thanks.
Thank you, Sarah. Simon next, and then Paul. Simon. Simon, you're still on mute.
Sorry, that didn't come up. Yeah, just couple of comments and one question. So just on yes, the use of VCS and primary care capacity, I think we really should support that. We need a number of creative solutions to workforce gaps. One of them is using partners to help fill some of those gaps in. So I think we absolutely endorse that. Secondly, Sarah, I think you're right. It is time for a review of the governance around the collaborative. We do want to move it forward, don't we? I remain really committed to this. I think this kind of provider collaborative is really important to how we move forward, and we can learn lots of lessons from this in the other provider collaborative work we want to do, but that is about empowering, and the governance has got to be right to do that. And thirdly, a question, Sarah, about dementia diagnosis. So I'm interested in the Living Well with Dementia pathway. Having had years of challenge from various national and regional colleagues about our low levels of dementia diagnosis, have you got any idea of a trajectory as to kind of how we might see that diagnosis improve over the coming year?
Sarah, do you want to come in on those? So I think that there were two really about dementia there, weren't there? One from Sarah about the actual response once people have got a diagnosis, and the other now from Simon relating to sort of what this new partnership arrangement or the new pathway might do. So do you want to come in on those two together?
Yeah. So just in terms of people being diagnosed, we need to be quite careful around all of this, don't we? Because actually the decision of an individual and their family to receive that diagnosis and to work with it is quite hard. Some people don't immediately want that diagnosis. So actually there is a programme that's of support, if you like, for the family in a lot of circumstances and the patient to decide how they want to manage this transition process, because it's a big life change, isn't it? Thinking they have a diagnosis and what that might mean. So really important to have a very strong partnership with the patient around that part of the process. I think, am I positively assured there is provision in place? I think it's like a number of things, Sarah. Yes, there are significant services, there is significant VCS input. There will always be the scope for more, won't there? And making sure people have all of the services they need. And certainly people's views on some of these things were picked up when we recently refreshed the ICS mental health strategy and dementia strategy. We took a lot of soundings from members of the public and patients and families and carers to really understand what were people looking for in terms of our next priority area of focus. So I would give it in that context. Support what Simon said. Partners filling the gaps, I think, is an important point just to comment on, because I think whilst in this occasion it is partners coming in to support a gap, I think it's also about us moving very much to a model that doesn't medicalise everything. So I think the partner offer is also really helpful in terms of offering that early intervention and support and connecting individuals with their local community office. So I think it's important in that context. The dementia element, as I say, has been quite challenging, and we have put a number of initiatives in place, including the Diadem project in nursing homes and including some targeted support into primary care to work with looking at people on the registers and patients on the practice register. Jenny, did you want to say anything else on the Living Well in Dementia pathway, because you've been more involved in those conversations?
Yes, thank you. So it's the national pathway that's been in place for a number of years, but it does take us through from prevention all the way through to end of life, and obviously focusing on supporting people who are diagnosed. I think in terms of your specific question, Simon, in terms of trajectory, it's probably worth noting that the national reporting has halted because there is a review taking place in terms of the targets, how they'll be calculated, and the expectation. Trajectory, certainly the data is primary care data, so we are working to refresh the trajectory. It is always quite hard to determine exactly when we will start to see those improvements, and I think some of it just reflects the complexity, and I think the ask of the ICB really is around system support. So we are identifying a number of barriers. So for example, in social care provision, where actually the diagnosis may not be helpful because your current provider doesn't feel that they are appropriately registered, for example, or concerned that somebody would then have to move because some of the social care processes are not helping that way. So that's some of the barriers that are coming up that we do need to work through. And I think as a system, our citizens, probably we haven't helped them to fully understand what the benefits might be of what is actually quite a frightening diagnosis. We will all have experience of friends and colleagues, family members who may be having cognitive issues, who may then progress to dementia, and I think that's more of the work that needs to be done more broadly in the way that we are overcoming the stigma around mental health. I don't think we're quite there yet as a society in terms of dementia.
Thank you, Jenny. Thank you, Sarah. Okay, there's a few more comments, so I'll take those again in a sequence, if I may, and then bring you in. So first of all, Paul Walker, and then Nigel Fraser, please.
Okay, thank you, and thank you for a comprehensive and report there. I had 3 quick points. Simon's kind of touched on the first one. I'd just like to go a little further with that around the early recognition and diagnosis. And the figure and performance at the moment, and given all the things, Jenny, you've talked about, and Sarah, in terms of the current context, I would imagine that in your improvement plan, you will have set your own targets in terms of where you want to get to. And I think, given the importance and significance of this particular area of work, and I think it's kind of assurance back to the board of progress against those targets is something that I would like to raise. And within that, I keep coming back to my kind of place-based initiatives. What more can communities and the work and establishments we have in place do and be activated to provide greater and more intensive support to people and their families? So that's the first point. And I think the second one was around kind of the forecasted overspend and how that going to be managed or mitigated, and is that pressure on beds still there today, or has that been released? So we begin to try and offset some of that cost. And then thirdly was just around the national outage. Sarah, you were saying, you know, to get much work done by the end of January. When do you envisage kind of it to be 100% back on track there? Because I know that's causing significant challenges and problems for you every minute of every day.
Paul, if it's all right, Sarah, I'll just get Nigel in and then come back to you. Nigel?
Thanks. Just one observation and one question, if I may. So the observation is about IAPT and the voluntary sector, which I think is a great innovation. My concern is that we might just reflect worse in national metrics as a result of that. And I just wonder whether a sort of an associated metric saying including this activity in voluntary sector, because otherwise it won't be, you know, we won't have the assurance of the actual work being done for these to support this group of patients. So I just wonder whether that might be useful. And the my second question was about the workforce. Every service has a workforce challenge. There's no, you know, that is across everything. And the question was about how the rollout of the R's workforce for mental health is happening, and how do we benchmark to other areas? Because obviously this is a route of expanding mental health provision within PCNs, and you know, would be useful for our patients.
Thank you, Nigel. So there was quite a lot in there, Sarah. I hope you captured it slightly better than I did. But I think just to be clear, in case people don't recognise the term, the R's is the additional roles, isn't it, within the PCNs? So, yep. Sarah, are you able to sort of pick up those points reasonably easily?
Yeah, I will do. Just on the dementia target, obviously at the moment we're aiming for the national target required of us, which is 67%. We do have a trajectory, but it's not in this report, and more than happy to include trajectories as well as the performance, which we have done actually on some of the areas, but not on dementia in the report, so we can pick that up in future. What more can communities do? I mean, there's a very long answer to that question, as I'm sure you know, Paul, but it's just about how we support in communities and how we enable people, how we reduce stigma, isn't it? And how we wrap around our families with a lot of the local signposting and offer to make sure people are able to access services, which we know is challenging on a whole load of levels if you have dementia or you're caring for someone with dementia. I think it's a really interesting question. I'd quite like to take that to the collaborative, if Jenny agrees. I think we should perhaps reflect on that at the collaborative about what else we could do to help, that we could work with communities to deliver. In terms of the forecast overspend, yes, there's a detailed review going on between NHS and the council around the Section 117 placements. As you know, there's quite a large and growing number of people who are entitled to Section 117 aftercare, and a number of them have very complex needs. So there's a detailed review underway at the moment. The collaborative has reviewed the initial emerging findings from that, and we're expecting it to come back shortly when that review is complete. But that is looking at every individual and whether the offer of aftercare is appropriate for their needs now, whether there's any adjustments we need to make. The out of area placements, we have a recovery programme. It is coming down slightly over the last few months, but as I say, a key thing is looking at some of the longer term service provision, so we don't have this situation on an ongoing basis. But again, each patient is being reviewed in detail to see what alternatives we can have. In terms of care notes, I'm hoping that by the end of February, but certainly by the end of March, that we'll be fully operational again. The problem we've got is there is obviously then sort of circa 6 months data that isn't on the care notes system, that's on the temporary system or filed in a number of places. So the challenge is to make sure we can recover all of that information, particularly activity information. So there's a discussion going on with all the trusts affected around the impact on performance information with the national team. But at the moment, we're just being advised to do everything we can to recover as much as possible, which we're doing. But from a clinical point of view, in the next 2 months, I'm hoping that clinicians will be back on the system, because you'll be well aware, Paul, it's affected our ability to respond quickly to some of the reviews that are required, particularly, for example, for looked after children's one example. But you know, for us to do a report of all of our interventions with that child with quite large chunks missing has been challenging. So we're doing our best to get everything back onto the system as quickly as possible, but performance data will take a little longer to recover. Just on Nigel's point, in terms of the work being done in PCNs and the voluntary sector, I agree, Nigel, it's not an easy answer because our metrics are submitted through an automatic national data set to the central team, which doesn't sort of create the option. But what we're trying to do is make sure that work is fully evaluated and that the outcomes for patients are collected in the same way that we do in some of our other services. And really, we have raised this with Region, and we hope that they are very interested in the outcome of this work. So I think certainly once we've got an initial evaluation, I would want to take it back to Region and the national team for another discussion. I think there is a national recognition that the IAPT model is quite specific and that it probably now is coming towards the time to be reviewed. So I think there is an openness for the conversation, but actually collating all the data is slightly harder. But yeah, absolutely critical that we have a clear and effective evaluation so that we can show what we've managed to achieve. And just on the ARS roles, the appetite and uptake is really variable across the country. I would say we're probably lower than some other areas overall for mental health ARS roles. I think a lot of practices have chosen to use some of the ARS investment on other professional groups like physiotherapy in the first instance, but we're very open to the discussion. The challenge is obviously the joint funding element, which means that some of the workload from trust activity needs to come together with the primary care work. But I think the neighbourhood mental health teams, which are now in place, are very much working in that direction, aren't they, where we're one team, one population, and we need to be creative about how we work. So I think that is work in progress, but I think there is regional are open to thinking about that moving forward.
Thank you, Sarah. And then finally, Kath.
Thank you, Chair. I've got a point of awareness on board, and I'm going to do a wee point of promotion, cheeky point of promotion as well. So just for awareness for the board, the ICB and the Health and Care Trust have received our Regulation 28 from the HM Coroner. This is prevention of future deaths related to mental health. We're obviously working on both the response to that and the points of action for improvement. So just to give the board assurance that we're working across that in the system. And then just in, I think it's worthwhile mentioning as well, just a bit of point of promotion and the theme of the patient story, and obviously the mental health deep dive, the excellent mental health deep dive founded by colleagues. I just wanted to raise awareness of the Orange Button campaign, the Herefordshire Worcestershire, as part of the Herefordshire and Worcestershire Suicide Prevention Suite. It's an excellent community programme. I've recently completed my training. I would advise it for anybody, and it is about what Jenny said earlier on about reducing the stigma and having the conversation. So thank you, Chair.
Thank you, Kath. Sounds like something we should maybe be helpful for everyone to receive the link or access to that information so we can all participate in the training and yeah, raise our own awareness. Thank you very much. A really comprehensive set of inputs and discussion. I actually just wanted to comment. David and I think, did a visit a while ago to various services in the Health and Care Trust, and we actually we met the team. I think David Whiteman and I, who were involved in the Athlon ward closure and the hospital at home service, and I think we had a very enjoyable discussion. They were incredibly passionate about the work they'd done and the service that they developed. It was certainly very impressive from our point of view, I think. Would you agree, David?
Absolutely. So
yeah.
Absolutely, and also they were enthusiastic, energetic. They were a brilliant team.
Yeah. So you know, I just really wanted to say we were impressed with what we heard and the response from patients and their carers about the nature of the service. So I look forward to hearing more about the evaluation of that and conclusions of that. So I think Sarah's asking us to really support a number of the initiatives. So the current review of the governance arrangements, which was mentioned, endorsing the use of the Living Well with Dementia pathway, the shift of resource to VCS partners. And I think the important point was made that whilst, you know, that is helping us address some of the challenges we have with resource, it's also a kind of future way of working that actually is potentially a positive development anyway, that we should support. And also support the implementation of an ICB-led assurance process. The remainder of the report was very much about us understanding, you know, the range of things that are being done at the moment to support recovery where appropriate and indeed performance where it's really positive as well. So thank you, Sarah, and thank you to everybody for their comments and questions. So we move on to the next item, which is the Herefordshire Children's Services Inspection Report. This, I think Paul raised this at our last meeting, indicating that it would be timely for us to be aware of it, and particularly because there's a multi-agency aspect within it. So Paul, do you want to highlight any key points relating to this?
Yes, I'm not going to go through the full detail. I'm conscious of time, and as you say, Chair, you've heard me raise this a couple of times before. What I did want to do was kind of formally bring the improvement plan to the board, and also a reminder of the outcome of the Ofsted inspection report. And you'll see the kind of key recommendation. The second recommendation is kind of looking for board to look at where the connections are with existing activity and partnership work across those improvements. Really important for us to get that multi-agency partnership approach in terms of strengthening our response through the improvement plan and how we work, how we build on the work that we're doing at the moment to make even more progress. So that's kind of what I wanted to have in mind. But just as a reminder, full Ofsted inspection during the summer, outcome inadequate across the board of children's services. Children's Commissioner appointed to look at capability and capacity of the council's ability to deliver the improvements. Her report is just reaching its conclusion, and we expect it to be with the Minister by the end of this week. That report remains confidential, and we would expect to have some contact within the next 2 or 3 weeks as to that response. And clearly working with the Commissioner in the meantime. Having seen the report, I think fair to say that it recognises the long-standing and deep-rooted issues that we know about in children's services, but it does point out that those have been really in place since 2012, and the issues that were presented through the recent Ofsted inspection have been features of Ofsted inspections and visits since 2012. But you'll see the improvement plan responds to the 9 recommendations, plus picks up on the outcome of the recent peer review into our SEND service, which we're working closely with colleagues on the board to make good and positive progress. And the format within the improvement plan is to pick up the 9 recommendations, focus on expected outcomes and what we call measures that matter. And I think that's where I'm looking for support from colleagues in the board and across the system in terms of where the connectivity is with the improvement plan and key partnership activity, and how we bring that together. You'll be pleased to know we have been making some progress recently. We've seen some small steps, some positive progress, and the impact of the work that's been done, not just within children's services, but a very positive presentation at the improvement board last week through work across the service, particularly with colleagues across the health sector and police. What I wanted to share with you is a recent move where, to increase the pace of change and delivery of those improvements, we're introducing an assistant chief executive for children's services improvement to bring support, advice and challenge to children's services, and a focus on delivering our immediate priorities within the service, to ensure that we are ready and prepared for when Ofsted return, which is likely to be in 8 weeks, and for putting in place the strategy in preparation for the full inspection of our SEND service, which we expect to be sometime between now and June. So that's the kind of latest picture as to where we are. And, you know, without going through the detail of individual recommendations, you know, the ask from me is to look at where the connectivity is. Are we doing all we can, both within colleagues individually and within partnership activity across the system, and to take the opportunity, if it need be, happy to support presentations, further feedback within individual partnership activity to bring the detail to life should that be needed. Thank you.
Thank you very much, Paul. Can see that people want to come in to make a comment, so let me just make sure I know who. Yes, Russell first, then please.
I just wanted to make a general point, Paul, on behalf of our citizens. I know all of this is incredibly difficult, Paul, for you and your teams, and on behalf of the citizens, I just wanted to thank you for your commitment and efforts to try and improve the situation. It's not easy, but you do have our understanding and support, and please do let us know if there's anything more we can do as system leaders to support you.
Thank you, Russell. Thank you.
Thanks, Russell. David, and then Vicky.
Thanks, Krishni. Yeah, I think the improvement plan, Paul, is really great. What I'm struggling with is exactly what you're asking for, which is support from the system, because when you look at improvement item 2, sufficiency and stability of staff across the workforce, everything, almost your whole plan is dependent on that, and actually that is the part of the plan which is all yellow or red. So I don't know how you're going to fix that apart from with support from the rest of the ICS. So it's really echoing your point about you need support and ideas from the rest of the ICS about how you can do this. I think it starts exactly with that improvement plan item 2, which is how we can help you with staffing.
Thank you, David. And I think Vicky wanted to come in.
Yeah, I think it was a very similar point to David's. So it was just really understanding, exploring, Paul, just the connectivity point that you make in terms of multi-agency, as well as our oversight as an ICS as well. So just trying to understand and explore that to see how we can support.
Okay, Paul, do you want to comment on the workforce bit at this stage, or do you want to make any response to those?
I respond on the workforce. I suppose there's two things immediately in terms of our recruitment and retention strategy, and around payment systems. You know, our retention payments, which we've introduced this month, and our kind of golden hello welcome payments, which we put in place for social care staff, which works across both adults and children's. That's the feature of that work. The recruitment strategy that we put in place, which is now gathering momentum in terms of, you know, our move from 50% interim or agency work involved in social work through to an era, you know, the target of 90% and the progress we're making there. And I think part of that is the work that our HR director is doing with a number of colleagues on the board with regarding kind of a public sector approach to recruitment and retention, and a single approach in terms of employment and how we present almost the public sector offer within the recruitment market, not just within the local authority, but across colleagues and across health as well. So that's something which is gathering momentum, and I know Jane and a number of other colleagues are close to that detail. but it's something that through kind of the work that we're doing through the public sector leaders group, that we establish we work towards a single point of employment and presenting vacancies and recruitment opportunities to a wider audience in the context of telling the story of Herefordshire and what's the offer of Herefordshire, and a strong Herefordshire offer, not just in terms of quality of life, but in terms of employment opportunities, quality of our schools, education, our cultural offer, etc. So a number of things coming together for which could all benefit from there. But we're absolutely right. You know, our transition from largely interim agency based to permanence is the cornerstone of kind of consistency, delivering on expectations and standards.
Thank you, Paul. That's really helpful. I just wanted to sort of particularly pick up, I mean, the other bits that struck me, and I referred to it earlier, there was obviously an element of this relating specifically to access to the appropriate therapeutic interventions for children and young people in care and care leavers, and that referenced dentistry, mental health support, and of course then the send offer as well. Mary, I think if I remember, we've got a children and young people's board, haven't we? Are we picking up, how do we as the sort of health partners here sort of make sure that we're giving the right support to the local authority and that join up of our health offer, particularly in relation to looked after children? I don't know if that's still the appropriate term, but you know, children in care. Are you able to help with that, Mary?
Yeah, so the Children and Young People's Board for the ICS has national priorities it deals with, and there are 2 ICS priorities, one being SEND and one is mental health in children. So we are developing strategies in all those areas that are designed to help place to implement and deliver the improvements they need. I think particularly for Herefordshire, it's welcome we've got the Partnership Summit this afternoon, Paul, haven't we? Where it's the first time I think we've really all been around the table, apart from the Improvement Board, to really debate how we tackle some of these very, very difficult issues. The looked after children issues, particularly, you know, I've had feedback that we need to make some improvements, social care need to make some improvements. We need to join that up this afternoon. What exactly is going to make the difference, and how can we do that quickly to support that? But just agree with the previous comments, workforce is by far the biggest challenge, you know, from a health perspective as well as a social care perspective. We've seen probably for the first time ever, I think, the resilience in children's services as lowest, that's from paediatricians down to specialist nurses, down to health visitors, everything. We've got a challenge. So we've got to look at a different workforce. And I'm aware Katie's starting to pick up some of this. It's not a quick win. I don't think that's a quick win in that at all. I think this is medium, longer term. But I think picking some of that up in the Partnership Summit this afternoon for Herefordshire will help.
Thank you. So that sounds like a key inflection point, really, in terms of bringing some of that thinking together. So, Paul, is there anything more that we can do today? I'm conscious that that's sort of due to take place, but and potentially, I think we just need you to kind of tell us where you need more support and where you feel we're not responding, or hopefully we are, but. It sounds like there's some steps to go through before we can further define and refine our plans. Is that a fair position to present?
I think we're right in terms of the Partnership Summit we have this afternoon. Does what it says on the tin. It's kind of bring us together to look at how we tackle those very difficult challenges across children's services and do that within our own organisations and then together. So that's kind of work in parallel. I think for me as the ICB, I want to make sure that colleagues are aware of the challenges, and as we make progress over the next 3, 6 and 9 months, the progress that we're making and what further support we need as we build on the outcome of the Partnership Summit and continue to make progress. So I think I'd like to get, with your support, come back in either 3 to 6 months to say, this is where we're up to. This is the additional support and help that we need.
I think that would be really helpful, Paul, because I think we'd all want to be assured. It's clear from the inspection report that a sort of multi-agency response to this is an important part of the improvement requirements. So I think we would welcome that. So thank you very much for bringing it to our attention. And bringing us more of the detail, I think, because we certainly, I know you updated us last time. So we'll plan for having it back on our agenda to get a feel for where we are and whether we're making progress and what further support you need from us in 3 to 6 months, which we can plan for within our agenda.
Thank you.
Thank you. Okay, so the next report we have is the System Quality Delivery and Resources Report. I think there's a range of executive authors in this report. Conscious really that we are a little bit tight on time, so can I just suggest we take the report as read, but Mary and other colleagues who particularly want us to note anything from the report that may have changed or maybe an update, it would be really helpful to do that. But I do want to make sure we still have enough time for questions and comments, Mary. So is there anything you particularly want to draw to our attention?
Just a couple of things, that's okay, thank you, Chair. I think even since I've read this report, the last, we've started this meeting, the last 2 to 3 months have been really challenging. In the last week, 10 days, we've seen a significant improvement across the ICS and regionally with ambulance handover times. And just assurance, our biggest risk of those patients in their own homes not getting an ambulance in a timely way, we haven't seen evidence of that for at least 2 weeks now. So that is really pleasing to see across our system. But I think the improvement work is carrying on and needs to carry on because we had some very difficult days in recent times. So it's just we've outlined for each place what has been happening, what their improvement focus is, and there's plenty of support coming regionally to us as well if we need it to support the improvements. That's really what I want to say on urgent care, if that's okay. Elective care, just pleasingly, obviously Worcestershire is tier 1. Elective care, biggest concern, but from the elective and the 78-week position, we have seen some significant improvements again, which is welcomed. And we're still on trajectory by the end of March to hit our target. A lot of work to do in the next few weeks to be absolutely certain of that, but there's extraordinary efforts going into making that happen as well. I just would like to mention the GIRFT. We had a review, our second review by Professor Tim Briggs in December, and the letter came in December to us. It shows the significant progress we've made as a team across the ICS in GIRFT, but it also shows us, which I'm sure every chief executive is aware of, the areas of focus that we need for the next few months, and which could help to make some real inroads into our long waiters. Cancer remains one of our biggest challenges, although again we're seeing some shoots of improvement, particularly in Worcestershire. There's a lot of work happened on the front of the cancer pathways that's made significant improvement. We're now focusing on the backlog. We got to put as much energy into that as we have everything else to make sure that those patients get access to treatment as quickly as possible. So lots of work going on, lots of scrutiny, lots of weekly reporting that's giving us assurance that we're doing the right things. It's just making it all happen. Big risk to it is the industrial action that may help us, may run us, take us away from those targets if it's implicated in those areas. But that's really an overview of the performance where we are at the moment.
Thank you, Mary. Jane.
Yeah, I was just going to add a couple of comments, but particularly the chart that's on page 3 of 10, which is occupancy. So I guess the first thing is clearly the Wye Valley data is wrong, saying at that point in the year there was we've got 9% of our beds empty, and we've fixed that reporting problem. But I guess I'm highlighting a bigger problem. So the NHS reporting system for this does not allow you to report over 100% occupancy, and I think that's a real problem because what it's suggesting to our population is that we've got enough beds because we never go over 100%. For this week, we had 25 patients boarded on our ward. So those are people in a bed on a ward that is not in a proper bed space. They're in a corridor. They're the 5th patient in a 4-bedded bay. So the real picture was we were probably 110%. Plus we'd got another 34 patients in ED waiting for a bed. So apologies that we haven't got our data right, but even if we had got it right, it would only say 100%, which is a long way from what the real picture is. And that Russell mentioned that at the beginning, you know, the stress and pressure on staff, because clearly we can't, you know, we have not been able to create the additional temporary staff to properly deal with that number of patients. And then, of course, there's stress and pressure on patients and their families of that position. I just think we need to recognise that, and I think the National Data Reporting System doesn't enable us to do that.
Thank you, Jane. I think really helpful to share that, I think, so that everybody appreciates that. Don't know whether we can do anything about the reporting element. It's perhaps something we need to comment on and maybe pick up at our next quarterly review with the regional team.
I've been estimating this for a long time.
Okay, thank you, Mary. Any other comments or questions regarding the content of the report? I don't particularly want people to feel, I think we have got a bit of time still to take a few questions if people want to comment. Mark?
Thank you, Krishni. Did you just want me to update on this point about the in relation to the system finance, which is included in the report? And I'll be very brief, just to say, since we met previously, our 14.8 million deficit plan has been accepted now with NHS England. So there's progress in that regard. The challenge now is the delivery of that. We had ICS Finance Forum last week, where there was still commitment from all partners to deliver that control total, which would avoid then the revenue protocol, which I referenced in the last public board meeting. And we've had a discussion about the quality and resources committee as well. The big drivers still within there, we've got pressures around agency, which again is driven by the workforce challenges. That will put pressure as we go into the new financial year, because again there's a tightening around agency controls. So again, that's an area we need to get to grips with. And also we're behind at the moment on our efficiency programme. We are mitigating that non-recurrently. The challenge then becomes the underlying position is a problem as we go into the new financial year. So effectively, we're just kicking the can a little bit into next year, and we're going to have to make some informed, difficult decisions really about how we manage the finances next year. So that's just a very high level summary, Krishni, of where the overall system positions at the moment financially.
Thank you, Mark. David?
Sorry, was that me? I coughed at that stage. Was that me, Krishna?
Sorry, yes, David Whiteman.
Yeah. Yeah, it's just a very quick question, Mark. The agency cap delivery. So we will obviously exceed the agency cap. Are there any consequences beyond the fact we're spending more money on agency staff? So is there any consequence from NHSE for us exceeding that?
So there's a lot of scrutiny and a lot of additional reporting, and what are our recovery plans around that. There are no financial consequences as a result of that, other than the bar will be set higher as we go into 23-24, because of the way that they're currently working through how they set an agency limit then as we go into the new financial year. So it just means the challenge is harder, because there'll be expectations that we need to go further.
Thank you, Mark. Mary, I just had one question relating to 78-week waiters. I know one of the issues that NHS England, well, certainly the regional team sometimes raise when we're on our chairs calls, is about the non-admitted numbers and the risk of that converting to patients on the list. And I'm also conscious we've been asked to make the bookings, I think, for everybody by the end of January in order to be able to hit the target. So I just wondered if you have a sense of, you know, any kind of assurance about our ability to do that, and also that risk around the non-admitted percentage.
Okay, thank you. So I don't know if Matthew wants to come in, but we meet weekly with the regional team, with Mark Brassington as a tier one, jointly as from the ICB and from the Acute Trust, and we go through all of that detail. So there is a plan to get all the non-admitted done by the end of January. The conversion rate, if it stays as it is, which it largely does all the way through the year, there's not really great variation. There is a plan then to treat all those patients before the end of March. But as I said, there's a lot of work to do, and a lot of it is dependent on workforce. So that is the one risk that we have. Matthew might want to come in on that.
Thank you, Matthew.
Yeah, thanks, Krishni. Thanks, Mary. I think Mary's absolutely right. I spoke to Mark Brassington on Monday, and I think he was certainly relaying a greater level of assurance from last Friday's meeting. So I think that's positive. I think it is, as when we made this point last meeting, our understanding is that the next stage of industrial action for the RCN is going to focus quite a lot on the elective recovery plans within acute hospitals. So I think probably the risk that we identified, Krishni, last meeting is probably going to be greater across the next series of RCN strikes at the beginning of February. So we're just going to need to look at how we mitigate that. I mean, we had quite a number of nurses from theatres go onto the picket line in the pre-Christmas strike action, so we're going to need to look very closely about how this impacts on our plans. But as Mary says, we are seeing the numbers of long waiters coming down, which is great news for patients, as this has obviously been a very tricky time for patients waiting to be seen.
Thank you very much, Matthew. Okay, thank you also thank you to both Mary and Mark. I don't know if Kath or Will wanted to make any final comments before we move on to the next item. No, you're both okay. So thank you. I appreciate we haven't had a huge amount of time to discuss that, but it's therefore noting an assurance, and undoubtedly we'll have an opportunity through the quality committee, quality resources and delivery.
There was one thing, if we've got a second, Krishni.
Yeah.
I just wanted to thank. I went and had spent a day in Worcester Acute last week, just before the last ambulance strike, and I just reflect back to something I think Jane said. The clinical staff on the ground in the trust were, I think, making heroic efforts in a very, very difficult situation to manage the clinical risks they were taking and they were seeing with their patients. There was some tremendous pieces of work going on there in very difficult circumstances, and I just really wanted to commend the staff on the ground, actually in the acute trust particularly, but I know the same was happening in the community as well, in primary care, on their resilience and their dedication to the patients, which was superb in very, very difficult circumstances. So yeah, I just wanted to relay that back to the system, which was fantastic.
Thank you, Will, and I think we would all commend that support and recognition. Okay, moving on then to back to you, Mark, for the ICB financial plan and delivery. Did you want to draw anything to our attention in relation to that?
Thanks, Krishni. So I'll take the report as read, just pulling out some key points really. From an ICB perspective, we are still slightly behind plan from a year-to-date position, so we're 1.8 million behind plan. Our plan's the 6.6 million surplus. Since the previous board update, we've done a lot of work looking at those unmitigated risks, how we can mitigate them, looking at further opportunities, and I'm pleased to say non-recurrently we believe we can mitigate those risks, which will get the ICB part of the system back to its 6.6 million surplus. We have got some pressures though we're seeing, and Sarah touched on a couple of them when she talked about the section 117 and the mental health placements. We are seeing that financial pressure, and that will put challenges as we go into 23-24, and we'll have to work out how we manage some of that growth, both from a price perspective and also from a growth in numbers perspective as well. We talked about continuing healthcare previously, and the action plan there still continues, and we're working through that, and there's a lot of management intervention there. So really, Krishni, it was just to say that we are on track now with our 6.6 million pound surplus. There is still some risk to that, but we're working through mitigating that, and overall that's where the ICB part of the system portfolio is at this stage.
Thank you, Mark. Graham?
Thank you, Krishni. One comment and one question. First, just a comment, Mark, and it relates back to the system paper. I do get a great deal of assurance and of thanks to yourself and the finance community and the finance forum for managing the position, albeit it's not perfect through non-recurring. That's really good at this position. The question is, Mark, I just wondered if you'd take the opportunity, because it was in Simon's report to the board last time about our position with the external auditor. It is of public interest and it is one of the key assurance mechanisms.
Thank you, Graham. So at this stage, we still don't have an external auditor for the ICB, as to effectively there's two parts to that. One, to cover and audit the 3 months accounts for the old CCG, and also then for the 9-month audit as we exit 22-23. We are working directly with national colleagues in NHS England who are having ongoing discussions with the National Audit Office and the Financial Reporting Committee, which is effectively the body that oversees and manages the external audit market, to look at how any mitigations or work programs can be put in place to mitigate the external audit conflict of interest elements. So we've got another live discussion with NHS England next week. Hopefully they'll have a resolution for us at that point, and I'll keep the board and board members updated on where we are to that at that point.
Thank you, Mark. That's useful, I think, to note. OK, so we note the assurance that Mark has provided relating to the ICB financial plan. We have now got the ICB committee chairs report. Actually, I think what that highlights is a number of meetings for various reasons didn't take place during that period, and some were not scheduled to. However, I think there is a reference to meeting of the Strategic Commissioning Committee, and I'm aware that a briefing did take place for the Quality Resources and Delivery Committee. So I want to just invite non-executive members if they wish to comment. Sarah first. Is there anything you wanted to add, Sarah?
No, I think that's a fair summary of our meeting. Thank you.
Great, thank you, Sarah. Vicky, did you want to add anything regarding the briefing?
Think just to say really the value of having our partner non-exec colleagues with us in that briefing. It was only an hour, so I'm not going to add anything else, but I think actually it provokes our thinking as an ICB about actually how we work with system partners to not duplicate and to make a difference in terms of that forum. So some more thinking and liaising with colleagues across all providers so that we can actually just make a difference.
Great, thank you, Vicky, and I would absolutely support that, and thank you to colleagues and chairs in particular for agreeing to support the initiative for non-execs from the trust in particular to participate. OK, so that's for noting and assurance. Hannah, do you want to cover anything from the board assurance framework report?
Thank you, Krishna. Only to draw attention to page 2 of the cover report, where we've noted a couple of changes to strategic risk scores.
OK, thank you. And can I check whether anyone would like to raise any comments or questions regarding that report and indeed the risk register, the strategic risk register? Vicky.
I think I just wanted to pick up on the priority 5, which is about developing and improving levels of assurance. And we've got audit committee this afternoon where we're going to be looking at this in a bit more depth. But I just wanted to say Emily Godfrey and Hannah have been developing those levels of assurance, and significant work has gone in. It's a really positive shift, and it'll come back to the board in time. I know that, but I just appreciate the work that's been put in with that. It's a really positive shift. So thank you.
Thank you, Vicky. And are there any comments or any other comments or questions? OK, well, we've rather gone through those last few items rather more swiftly than I anticipated, and now have 5 minutes to spare, which I don't think I'm going to fill particularly, but if there is any other business, there is a brief opportunity to highlight anything that we haven't had an opportunity perhaps to pick up earlier under pressure of time. Anything anyone wants to raise? Okay, no. So can I thank everybody for their contributions? I think we've had some really good discussions. Note that our next meeting is Wednesday, the 15th of March. And thank you to all colleagues who've attended, and thank you to members of the public who've taken time to observe our board. And I will close the meeting. Thank you, everybody. Bye.